sleep during the night. Really speaking. But you see anything on my face? You see anything on my face? Like I have not slept. There are two types, non-invasive and invasive. We call it non-invasive, we also call it in situ, and invasive we call it infiltrate. Okay? So we have ducts and lobules in the breast. So whether it arises from the duct or from the lobule, we divide it according to that. So non-invasive, ductal carcinoma in situ arising from the ducts, lobular carcinoma in situ arising from the lobules. But they will remain confined to the ducts or to the lobule. They will not cross the basement membrane. This is the difference. But in invasive or infiltrating, we have the invasive ductal carcinoma, invasive lobular carcinoma. So two varieties. In situ also ductal lobular, invasive also ductal and lobular. But here we have some more types, like invasive ductal carcinoma, which is not otherwise specified, which is not a specialized variety. Not otherwise specified. This is not a specialized variety. Okay? But in the ductal carcinoma, we have some specialized varieties, like these. These are the specialized varieties of ductal carcinoma. So ductal carcinoma, these are two varieties, ductal and lobular. But there are some special varieties of ductal carcinoma, which are these, like medullary carcinoma, like colloid carcinoma, tubular carcinoma, papillary and metaplastic carcinoma. Okay? So these are the varieties, special varieties of ductal carcinoma. Clear? So we have not special variety or not otherwise specified, or otherwise specified or the special varieties. So this is the classification. Clinical features, you know, how the patient will come, one swelling or more than one swelling. And maybe, you know, it will be hard swelling. Maybe it is attached to the surrounding structure. You cannot move it, like fibroid adenoma is easily movable. But it will not be. You can have the orange skin, orange-like skin, pure orange appearance because of infiltration of the skin and the lymphatics by the cancer cells. Nipple retraction, if it infiltrates, skin fixations. It depends upon whether it is the cells are infiltrating the skin or the lymphatics. It will lead to all these appearances. Distribution, the most common site is, you divide the breast into 4 quadrants. How? 1, 2. Okay? Upper outer quadrant, most common site. 50% of the cases. Upper outer quadrant. Upper and outer. Rest of the quadrants 10%. And in the subareolar region, 20%. Okay? So 50% is the most common, upper outer quadrant, and 20% is the subareolar region. Rest 10% you distribute. How you diagnose? One is the X-ray. A sort of X-ray which we call as mammography. It has increased the incidence of detection. So you have the ultrasound, you can use the FNAC, you can use the biopsies, you can use the molecular, genetics, immunomolecules, everything you can use, whatever you want to use. So because of these things, we can diagnose the cancer at an earlier stage and treat it. That is why the mortality has dropped from 30 to 20%. So this is in situ carcinoma. Look how beautiful it is. Not for the patient, but for us. This is duct, one duct. Okay. So cancer cells are growing within the ducts without crossing the basement membrane. Okay. This is another duct. All the ducts are filled with cancer cells. Normally there should be some space. There is no space. Cancer cells are growing. But confined to this is called in situ. This is only 5% of the cases. Invasive is like this, it is infiltrating. Look, these white specks, star-like growth, going into the surrounding structures, grossly, and look here. It is invasive. They are, without any minerals, they are moving. So these are all ducts, strands, moving here and there within the desmoplastic stroma. This is the invasive variety. This is 75% of the cases. So most common is ductal carcinoma invasive, most common, 75%. Now in situ carcinoma means there is proliferation of the cells within the ducts without crossing the basement. Yes. This is the simple definition. Proliferation of the cancer cells within the ducts that do not breach, that do not cross the basement membrane. There are many varieties. Sometimes this is the duct. It will be all filled with cells. Solid variety. No space remaining. Solid variety, okay? Solid. Cells fill the spaces. Sometimes comedo pattern. there is so much growth of the cells that the central part of the cells here, it undergoes necrosis because of decrease in the blood supply. So this is the full. It was first solid, filled with cells, all the cells. Then the central portion undergoes necrosis, and this is known as comedo pattern. Comedo pattern. There is central necrosis. So this is the comedo pattern of in situ carcinoma. This is the central portion of the cells undergo necrosis because of fast growth. Then the cribriform pattern. You have the spaces inside this solid variant. Okay, spaces, small spaces. This is punched out spaces, as if somebody has punched out these cells. This is the cribriform variant. Cribriform variant. Then you have the papillary. Like papillary, you can find within the ducts papillae. So depending upon which thing you will find, you can have all the ducts filled with solid cells. You can have central necrosis, comedo pattern. You can have papillae. You can have the cribriform pattern. So all the patterns can be seen. Is it clear?
Yeah. Necrosis because the cell itself is not reaching the cell.
Whenever in a cancer there is growth of the cell, fast growth of the cells. So some of the cells will not be able to find the nutrition for them. So they undergo necrosis. Increase of fast growth. It is only due to fast growth. They overgrow their nutrition. They overgrow their nutrition. In simple words. Invasive ductal carcinoma, how it will present? It will be hard, irregular, okay? And you will have the pure orange appearance. The skin over the breast will be pure orange, like a orange. So this is indication of a carcinoma which has infiltrated the skin and the lymphatics. So a dangerous sign. It's a dangerous sign. Sometimes it can infiltrate the nipple, which is called Paget disease of the nipple. The cancer cells can go into the nipple. This is called Paget disease. We will discuss later on. It can lead to retraction of the nipples. So nipple goes in. So if you find a swelling in the breast and the nipple is also going in, dangerous. It means there is retraction. This is going to be a cancer. And they can spread to axillary lymph nodes and undergo distant metastasis to lung, brain and bone. This is the histology. Different histological types are there. The most common is serous carcinoma. Serous means more fibrous tissue. As a desmoplastic response, the tumor cells are growing and the stroma responds by forming more fibroblasts, more collagen. Okay? So this is, see all this yellow, this pinkish coloring surrounding is the serous or the more fibrous stroma, dense fibrous stroma. Clusters of malignant cells growing in a dense fibrous stroma. Now, invasive ductal carcinoma can be well differentiated or can be poorly differentiated or moderately differentiated, depending upon the tubule formation. Three things are there: tubule formation, another is mitosis, another is pleomorphism. If you find tubules, there is less pleomorphism and there is less mitosis. We call it well differentiated. And if you do not find tubules, tubule is a normal structure in the blood, that's tubules. If you do not find tubules, very less tubules, more mitosis, more pleomorphism, poorly differentiated. This is called Scarf-Bloom-Richardson system of grading, but I do not include it in this. So you can have well to poorly differentiated, and 2/3 of these invasive ductal carcinoma express ER/PR receptors. So you can give tamoxifen, which is anti-estrogenic, and 1/3 our express HER2/neu. So 2/3 express estrogen receptors, and 1/3 HER2/neu receptors. These are the special histological types. Okay, we have the medullary, tubular, mucinous, papillary, and Paget's disease. We'll jump this. Yeah, of the ductal type, IDC. Invasive ductal carcinoma, these are the special. The previous one was non-special type, okay? No special type, or not otherwise specified. These are the special types. Little bit about the medullary carcinoma. This is rare, less than 1% of the cases. What you will find here, you will find large anaplastic cells with pushing borders, and in addition to that, you will find lymphoplasmacytic infiltrate in between the cells. And it is triple negative. What do you mean by triple negative? It doesn't have the estrogen receptor, it doesn't have the progesterone receptor, it doesn't have the HER2/neu receptor. So all the receptors. So if you get a question like, what is a triple negative? Medullary carcinoma is a triple negative breast cancer. Look, this large and soft, and here you will find cells In between, this is the lymphoplasmacytic infiltrate, the black cells. So these are the big anaplastic cells, these collections. In between, you find the lymphoplasmacytic infiltrate.
This is an example from basal-like carcinoma.
Huh?
This is an example for basal-like carcinoma.
No, it is not example for that. This is medullary carcinoma. It is like this, large anaplastic cells. Yeah, triple negative. Triple negative. All the receptors are negative.
What's the difference between basal-like?
No, that is different. You can come to my room, we will discuss that. Because we are running out of time. Paget disease of the nipple means there is an underlying carcinoma. It spreads through the duct, goes into the nipple. In the nipple, what it will cause? It will cause bleeding. It will cause itching. It will cause serious discharge. So it can cause all the things: tenderness, itching, burning, bleeding, and almost 100% of the cases will have in situ carcinoma, which is spreading to the nipple. Okay, so you will find these cells. Look, this is the epidermis. You find these big cells having clear cytoplasm. These single or in clusters, so they will infiltrate the nipple. This is called as a Paget disease. It means spread of the carcinoma into the nipple. Okay, so it will give rise to symptoms. 100% will have in situ carcinoma, all the patients. But 50% can have invasive carcinoma, underlying invasive carcinoma. So you have to recognize this thing. So if a lady is having these things on the nipple, there is itching, burning, you have to investigate for the underlying swelling. And you will find, if it is a Paget disease, you will find 100% having in situ and 50% having invasive carcinoma. This is the Paget disease of the nipple. No lobular. You have any class after this?
Yes.
Which one? Community. Who is going to take? I think my friend, then there is no problem. But he will kill me. He is very strict regarding. So lobular carcinoma in situ, again, the cells are growing within the lobules. But here, invasive, they are growing outside. In situ, relatively uncommon. You have malignant proliferation of small and uniform. Here you have small and uniform cells within the lobules. But it will increase the relative risk for invasive cancers by 8 to 10 times. This you should remember. It will increase the risk for the invasive cancers by 8 to 10 times. Invasive lobular carcinoma. It is much less common than the IVC, but this is lobular invasive carcinoma, more likely to be bilateral, affecting both the breasts, more likely to be multicentric. Many masses you will find. Classic histology is very important from the MCQ point of view. You will find strands and columns of cells, like these strands and columns in the lines, like in line they are running. This is called Indian file pattern. In a line they are running, Indian file pattern. And also the cells will grow surrounding the ducts. This is bullseye pattern, bullseye. Uninvolved duct in the center, surrounded by the proliferating cells. So you have two types of pattern. One is Indian file pattern, the cells growing in strands or lines. Another is cells growing around the ducts, which is bullseye pattern. And for the metastasis also, it has a peculiar metastasis, like it goes to the CSF, from the breast CSF, to the serosal surfaces, and to the pelvic organs. So lobular carcinoma has 3-4 things which are important. 1, bilateral and multicentric. 2, Indian file pattern. 3, bullseye pattern. Then 4th is spreading to unusual surfaces like CSF, brain, serosal surfaces, and pelvic organs. This is the spread of the breast cancer. It can go directly to the skin and muscles, from the lymphatics, axillary lymph nodes, or internal membrane. From the blood, it can go into the lung, liver, bone, and brain. So all channels it uses for spread. This is the diagram showing it. And what is the prognosis now? Depending upon the tumor size. Size is more, prognosis is bad. Lymph node. More lymph nodes involved, prognosis is bad. Metastasis, bad prognosis. We'll discuss in the next chapter. The next chapter, next slide. So invasion, tumors less than 2 centimeters have good prognosis. More than 2 centimeters, prognosis is bad. Lymph node exactly like that. Histological grade, well differentiated, have good prognosis. Poorly differentiated, have bad prognosis. Histological type, all the specialized types have good prognosis. Specialized type like medullary and all these have good prognosis. And worst is with the no special type, like the invasive ductal carcinoma, no special type. It has the worst prognosis. If hormone receptors are positive, ER/PR is positive, we have the better prognosis because we can treat it with anti-estrogen, which is tamoxifen. And if HER2/neu is overexpressed, we have the bad prognosis. Okay, but it can be treated with Herceptin, which is a monoclonal antibody. Now, what is sentinel lymph node? It is a primary lymph node which receives the lymph from a cancer. So it is the first lymph node which receives it. So why it is important? You cut it and see if it contains the cancer cells, it means cancer is spreading. So you can find the cancer in the other lymph nodes. If it is negative, it means chances of finding in the other lymph node the cancer is less. Okay. So this is sentinel lymph node. You can study it yourself also. This is the staging. Stage 0, in situ carcinomas. Stage 1 is 2 centimeter or less. So good prognosis. Stage 2, it may be 5 centimeters with up to 3 lymph nodes, more than 5 centimeters without lymph node. Stage 3, 5 centimeters or less with 4 or more lymph nodes. So lymph nodes are increasing. More than 5 centimeters without nodal involvement, with nodal involvement, any node, 2, 3, any. Stage 4 is the metastasis. So this staging, go home and read about it. 2, 5, remember 2, 5 size. Less than up to 2 or 2 to 5 or more than 5 size. And lymph nodes up to 3, 4 or more than 4, and distant metastasis. And male breast also you can have enlargement of the male breast, which is called gynecomastia, okay, or gynecomasia. It can be at puberty or it can be due to testicular tumors, due to liver cirrhosis. There, it is due to more estrogen. It can lead to enlargement of breast in the male. And carcinoma, you can find all types of carcinoma except the lobular carcinoma. Why? In the male. Because there are no lobules. So this is, if you want to ask any question, you can ask. It was like